A very good morning. I welcome you all to this interesting IC on developmental corneal abnormality. How do we systematically unravel and help in getting the accurate diagnosis? We'll get started with none other than Dr. Anil Mandal. He doesn't need any introduction. So he'll be talking to us on axonal rigor anomaly.
Open. Hello. Good morning, everybody. As I was telling, opening batsman in the open field, empty field. What I'll do in next 8 to 10 minutes is to give a perspective on axon-filled rigor anomaly, which is a diverse clinical manifestation spectrum and an individualized and thoughtful approach in the management. So, Axenfeld in the year 1920 presented or reported a case where there was prominent line in the periphery of the cornea in the inner aspect and iris strands bridging the angle to be attached to that prominent Solvay's line. 1930s onwards, similar cases were reported from rigor, and additional change was there in the form of iris abnormality. So it's a spectrum of disease, axon-filled anomaly, Rigor's anomaly, Rigor syndrome, when axon-filled rigor syndrome, when associated with non-ocular facial and systemic association. Look at the clinical manifestation of a patient. Actually, this picture is a newborn baby presented with corneal edema, and you can see the anteriorly displaced prominent Solvay's line associated with glaucoma. Glaucoma may be there associated with this condition in up to 50% of the situation, and it can present at birth and from early childhood to adulthood. Here is a patient, extensive iris change in the form of iris hole, ectopia UV, correctopia, and associated with dental abnormality, classic manifestation of axon-filled rigor anomaly. The common feature in these kind of cases are usually bilateral involvement, positive family history, there is no gender predilection, frequent association with non-ocular developmental defects, and there is high incidence of secondary glaucoma. You can see here the artist diagram, the structures involved in the manifestation of the disease. Here is a case, typical case of axon-filled anomaly. You can see iris change, correctopia, ectopia, and UV, and on gonioscopy it is seen that the typical feature, iris strands bridging the angle are to be attached to the prominent Solvay's line. A case where similar feature, but the corneal change is there in the endothelium, extensive change in the corneal endothelium. As I told, about 50% of the patients will be having glaucoma that can manifest at birth or in any time after birth to adulthood. When it is presenting at birth, the typical feature is like primary congenital glaucoma. And if you see carefully, you can see the additional changes or manifestations in the periphery of the cornea, and on gonioscopy, the typical change. The mechanism is, in addition to what happens in primary congenital glaucoma, is the iris strand. The outcome, the surgical outcome, when presenting at birth, usually it's a early surgery required, and surgical outcome is poorer compared to patients with primary congenital glaucoma. Now, Noel Rice in the year 1977 reported a series where 11 cases, 19 eyes underwent goniotomy and associated with extremely poor outcome, to the extent that he commented that goniotomy is probably contraindicated in axon-filled anomaly, or for that matter axon-filled rigor syndrome. Then what is the other alternative? Other alternative is external trabeculotomy. Compared to goniotomy, external trabeculotomy is probably technically little easier, because when the iris strands are there and associated with corneal edema, goniotomy is technically difficult. In addition to corneal edema or the corneal clouding, precluding good view of the angle, your iris strands come in the way. Compared to that, if you do an external approach, if you can detect the Slem's canal, trabeculotomy can be done. And when you are rotating the trabeculotomy probe, metal probe, probably there will be little stretch on the iridocorneal adhesion, but still you can do the thing probably much more scientifically compared to goniotomy. Here is the situation: trabeculotomy done on either side, then the trabeculectomy part, iridectomy, and then closure of the conjunctival tenon layer. We reported long ago in the year 2016 a series of 44 eyes of 24 consecutive patients in the first 20 years of my work at the L.V. Prasad Eye Institute. Till about 5 years, the success rate was about 93%. And after that, success rate gradually reduced. But one important thing, addition of 1 to 2 anti-glaucoma medication brought the success rate again to a very good or acceptable level. The acceptance is here: if the pressure is controlled with one surgery and then 1 to 2 anti-glaucoma medication, good control, probably that is the way to go, avoiding repeat surgery. But there are situations where patient will require repeat surgery in the form of trabeculectomy with mitomycin or implant surgery. A patient of primary, I'll say glaucoma at birth, and you can see preoperative and 1 year postoperative appearance. You can see once the corneal edema cleared, prominent Solvay's line is much more clearly seen. The other eye of the same patient, left eye, preoperative and 1 year postoperative appearance. This is 3 years postoperative appearance of the bleb, right eye and left eye. I really do not use mitomycin or any form of antifibrotic therapy in the primary surgery. And here is a situation. I'll give an example in the family, how diverse was the situation in the two generation. The boy you see here presented with neonatal onset congenital glaucoma associated with Axenfeld-Rieger anomaly in both eyes. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was done. Corneal edema cleared, and you can see the left eye enjoying good vision without any spectacle correction for myopia. But unfortunately, after 5 years of follow-up, the right eye was injured severely and we lost the eye. It ended in phthisis. The moment we saw the patient in the clinic, we inquired immediately the mother's eye, having clinical feature typical of Axenfeld-Rieger anomaly. Then I said, is there any other sibling? They said, yes, elder daughter is there. I said, we will be interested in seeing the elder kid. When she came, we saw here typical feature in the periphery of the cornea, and the gonioscopy revealed typical feature, and optic disc was normal. So we followed up the patient, intraocular pressure was normal. After about 13 years, the patient had developed glaucoma, and we did combined trabeculotomy, trabeculectomy respectively in both eyes, right eye followed by left eye. You can see the typical gonio anomaly seen in intersegment OCT, and this is the field defect which is now stable. But look at the mother's cornea. Here is the situation, right eye and left eye. Much more severe intersegment abnormality, but intraocular pressure was normal. There was no disc change or field change, and we followed up this patient for about 20 years. And in spite of extensive gonio anomaly seen here, but in both the eyes, there was no glaucoma. You can see the intersegment OCT. This is the disc change. This is the field normal, and we are following this patient. So here is a situation. In the same family, the youngest one is presenting with glaucoma at birth in neonatal onset disease. The elder sibling having manifestation at birth, typical clinical feature, but no glaucoma. We detected glaucoma after 13 years of follow-up, and the mother was having similar feature, probably phenotypically, at least intersegment finding-wise, much more advanced change, but there was no glaucoma so far. So disease manifests so varied manifestation, detailed evaluation, thoughtful approach, and individualized decision-making process should be there in this situation. In the when presenting late, maybe medical therapy first, and then the decision when to go for surgery. Thank you.
Thank you, Dr. Mandal. Very insightful talk. Any questions to Dr. Mandal?
I have one question. With the recent advances, are there any place for tubes? And what about the prognosis before?
Yes, the question is the way I look at it. Initially, tube implantation should not be the first choice. You mean implant, glaucoma drainage device? Yes. Initial surgery, if corneal edema persists, corneal clarity permits, and gonioscopy wise you can see the change is not very advanced, probably you can manage with the help of goniotomy. If one is expert in goniotomy, can do that. I have been trained more in the form of an alternative approach, because even in advanced glaucoma, even in early form of glaucoma, mild, moderate, severe, the corneal edema is very advanced in Indian scenario. There, goniotomy is technically little difficult. Probably 15-20% of the patients goniotomy will be possible, but a large percentage of patient goniotomy is technically not possible. We do external approach, external trabeculotomy, and in moderate and severe cases, we combine trabeculotomy with trabeculectomy. A dual pathway approach so that the long-term intraocular pressure control is good. The question of implant comes when first surgery fails, and then you are adding medical therapy, control is not satisfactory, then the question of implant, I'll say that is the way to go. Susmita, any comment on that?
It's varied, like you say. I mean, in India, somehow we are very wary of trying to use the children. And because when we follow them up long enough, invariably they don't seem to do so well. They do seem to rub, or there are more erosions, and so we are very wary of them. So we would go the Dr. Mandal's way of at least trying trab with trab first, but he's right. When we are foolhardy enough to sometimes try a goniotomy or a GAT after pulling down the adhesions, but somehow the Schlem's canal is very gritty. I think Dr. Deepak would be able to explain the pathology of why that is so, but it's very difficult to pass a suture through the angle, and possibly that would explain why goniotomy has such poor results, because I think it's an outflow problem more than in PCG. So what you think the pathology would be?
I'll show you a picture in my talk. So I'll show you a picture. Just two comments. I think, the phenomena that you're seeing genetically where successive children are worse, I think it's not uncommon in ocular genetic disease.
Yeah,
Phenomena
I
is
think
known
that
as,
is the
genetic-
usual way it
genetic
manifests.
anticipation. This is what the penetrance increases
Yeah.
with successive children. I think, Murali, you have seen this in a
Yes.
family. PPMD, correct? The very similar manifestation. And we see this in congenital glaucoma as well, that there seems to be a gain in penetrance with time.
Is there a reason, sir?
Yes. The other comment I wanted to make about is the term post-GM rituxan. I think we've shown both, and it's in your picture as well, that it really is not Schwalbe's line.
Yeah,
It really
yeah,
is
I know.
a nub of cornea that indents, decimates, and most often it's not at Schwalbe's line.
Mhm.
It's in other locations, more of a semantic thing, but that's the definition.
Yeah, I am aware of your publication. Excellent publication. Thank you.
Thank you, Dr. Mandal. We'll get started with Dr. Meena. Meena is a senior faculty member at Shankar Nethralaya, Chennai. She'll be highlighting in a cornea plana.
Good morning, everybody. It's always a pleasure to be a part of IC of Dr. Muralidhar, and I will share some of the pearls or what I have learned about cornea plana. So cornea plana, incidentally, has been existing even before the term sclerocornea was described. It was described as early as 1912 by Rubel in 3 siblings, but it was in the year 1935 by a publication of 3 authors who highlighted the entire spectrum of cornea plana. As of now, it is now described as a primary corneal opacity, and in the recent classification by Ken Nishan et al., it is a primary corneal disease. Its rare prevalence, or rather prevalence, is not known. It's described as a bilateral and so far non-progressive. It is for years to tell now whether it was slowly progressive. The OMIM classification has divided this into autosomal dominant and autosomal recessive types, where the autosomal dominant variety in the large population is described to be less severe, and the more severe, the autosomal recessive, is found to be more severe. What the Finnish and the Saudi Arabian groups have done is they have described these lesions and they have mapped this mutation on the long arm of chromosome 12 of the KERA gene, whereas for the autosomal dominant, the mutation is yet to be identified. The mutation lies on the keratin sulfate proteoglycan, which is a protein which is needed to maintain the interfibrillary distance in the cornea. This particular protein is prevalent particularly only in the cornea. In the mice which are null to keratocyne, they have been found to develop thinner corneas with shallower anterior chamber with faint opacities. It is seemed to occur somewhere at the 12th week of gestation, this kind of aberration. So we come to this child which came to me. She was an 8-year-old child who parents said that she was progressively having low vision, and her chart was very, very unique in that it was when I went through the chart, I saw the number of diagnoses that I could make out. She was diagnosed initially with ptosis with macular opacity, henceforth with microphthalmus with convergent squint. Somebody had even mentioned that she had endothelial dystrophy. In the following up years, in different centers, she was diagnosed as Peters anomaly and flat cornea, and she was planned for examination under anesthesia for a glaucoma assessment. And there and henceforth, she was not compliant to occlusion therapy and she maintained a low vision. Somebody had also mentioned limbitis and started the patient on anti-allergic medications. And finally, in 2022, prior to coming to us, somebody had managed to make a diagnosis of anterior segment dysgenesis with dyschorhea and fundal coloboma. So we'll come back to this case later. So I come to this child, case number 1, a patient, a male child born of non-consanguineous marriage. Patient noticed his uniqueness in having low vision and having disturbance in vision for distance and near. This was a referral from the pediatric ophthalmologist. So as a cornea specialist, I rarely see cornea plana directly, but my pediatric ophthal colleagues are very nice and send me these patients because I have educated them well enough how to pick up these cases. So this child, although had very high hyperopia, was found to have was not corrected initially, had nystagmus, gross stereopsis was poor, and the pediatrician, the pediatric ophthalmologist, was astute to pick up the different in the contour of the cornea. So all he could just say was, it looks oval shaped. So if you see the frontal picture of both the corneas, you would see that these are very prominent arcus, such that even though the cornea appears flat, the Vokes limbal palisades have overtaken the flatness and become more prominent. On the side profile, if you see, we have to lift up the child's lid, showing that there could be mild ptosis here, because there is the curvature of the cornea is similar to that of the sclera, so the lid is almost falling onto the cornea. In the lower picture, you will see that there is a faint opacity in the midstromal part of the cornea. We were able to image him and we could see high hyperopia, and the pachymetry was not too thin. It was seen to be around 500. Case 2 was a female child which we had seen in 2015 with similar presence of high hyperopia and with the pediatric ophthalmologist noticing a faint opacity, assuming that these are patients of Peters anomaly and where we would want to jump in and do surgery. And the patient was non-compliant to patching and had poor vision. And subsequently, we were able to see her from 2015 to 2018. She maintained the flat curvature of the cornea, and the pachymetry also similarly remained around 700 microns. The same child was seen around 4.5 years later, where there is so much resistance to patching and the vision keeps dropping down, and here there is dense nystagmus and the child develops a face turn. And you will see by the time the child was 7.5 years, she was referred to the low vision clinic. So you will see the temporal association of these children where the vision is slowly deteriorating despite the intervention by the ophthalmologist. And this is the characteristic phenotype of these pictures, where there is a lipoid-like infiltrates of the peripheral limbus, whereas the central cornea is just faintly hazy, and the corneal diameter appears less, like much so like a microcornea. And then this is case 2. Okay. Case number 3 is a child which we saw after some intervention because they were not able to pick up the cornea plana. Had already undergone optical iridectomy in the right eye, and when we saw in the left eye, this child presented with hyperopia and some kind of milder lower axial length. So there could be some variation because the right eye was intervened early. Maybe it was not picked up, but we were able to pick up the cornea plana because of the central macular-like opacity in the center of the cornea here. So it's very important to undergo to educate the parents about the need for genetic counseling and genetic screening, and we found that this patient actually had undergone genetic analysis. So case number 4 is also a long history of a decade. The father had brought this female child who wanted to bring this child because the eyes were looking small. He was very worried. And we followed it up between 2017 to 22, where the lower pictures you will see that the pachymetry has predominantly remained the same. Now, if you see the specular in these children, the numbers don't really actually are not very different, but they may vary. The coefficient of variation may be slightly higher. And in case number 5, in these children of where there was similar episode both in the sister and the brother, you will see this flat kind of cornea. It's very clear cornea, that much that you are able to image the specular microscopy is what I want to say. So always go ahead and take the specular microscopy when possible. But you will find that if the number doesn't vary much, the coefficient of variation may be higher. So again, between 2017 and 23, you will see the stability in the Kmax and pachymetry. There's not much change. That's why at present it is still not a condition which is described as a increase progressive in nature. So this is the photographs of the patient seen in 2017 and 18, where you'll see microcornea, dense arcus-like, and central macular opacity. His younger sister also presented noticing at a very young age, at the age of 1 year, where there is hyperopia and decreased vision. And if you see in her, you would see the typical disc-like features showing the thickening of the midstroma. And in the posterior iris, posterior cornea, the iris pigment was attached. The specular microscopy grossly looks normal, but a follow-up will be needed to know whether there will be really a change or stability in these cases. So this is how the OCT looks like. There is mid-peripheral thickening of the cornea. At the ends of this thickening, which is described as a plaque, there is a thinning of the cornea. And this is almost the case in most of the patients in which you would classically see the disc-like opacity in the slit lamp. In those patients where you don't see the disc-like opacity, this will not be seen. So again, there is hyperopia and there is low pachymetry. So another patient that we saw, it's not, so we saw a child where there is two children where the two brothers were affected, one sister and brother were affected. This was a family in which a 4-year-old child was affected like this, as you can see the picture, and the mother also had a similar picture, showing that maybe we have autosomal dominant in our Indian scenario. So the OMIM classification, which has divided this as autosomal dominant and autosomal recessive, typically describes this as a less severe and more severe, where the more severe, the autosomal recessive, is associated with mutations known to affect at the long arm of chromosome 12, iris abnormalities, maybe progressive edema, glaucoma, and ectasia, which is not very clear at this point in literature. And they may also be associated with longer axial length, meaning not only hyperopia, axial hyperopia, they are associated with myopia as well. And certain case reports of systemic hypotrichosis has been described. Typically, the keratometry of autosomal recessive is as low as 25 diopters, and the lowest diopter of an autosomal dominant is around 38 diopters. So if you see this chart, all those described countries described in red are those families in which autosomal recessive have been described by specific missense or non-missense mutations on the long arm of chromosome 12, especially from Finland and Saudi Arabia, where the genetics has been identified. And only anecdotal case reports have been described from the other countries which are described in white. And autosomal dominant pedigree will typically look like this, where there will be multiple generations affected, and autosomal recessive, where you can skip the generations and you can have a affection. So I've already described the role of AIOS20 is to look for the disc-like plaque and to look at iris adhesions when they are present and document them with AIOS20. And it's important to temporarily take specular microscopy, because they can be associated with decompensations and also show lower coefficient of variations. And most of them have been associated with normal axial length, but more so we need more data to see what is the actual axial length in these different geographical variations of this particular condition. So glaucoma, both open angle and angle closure glaucoma has been noted. That is why another important thing is to follow these children. And ectasia has also been noted. And rare conditions like duplication of the iris and associated of different mutations like PITX2 mutations with the same phenotype have been described. So the differential diagnoses are any other primary and secondary corneal disease, microcornea, microphthalmos, and nanophthalmos. So vision rehabilitation is very important. You have to identify the cause of high hypermetropia, treat the accommodative esotropia in these patients. Spectacle correction is very important. Contact lens fitting where and when possible, and treat the ametropic amblyopia, and look for rare corneal decompensation and glaucoma. Penetrating keratoplasty and cataract surgery may be included if these grow up into adults with good vision. Keratoplasty has almost never been ever described. The take-home message is we have now described a condition which is bilateral, symmetrical, mildly progressive maybe, with known clinical features. Document as much as possible. Refer to the pediatric ophthalmologist for amblyopia therapy. Genetic counseling and testing are very important to identify newer gene mutations maybe, and long-term follow-up, especially for glaucoma management. And we come back to the first case where we saw, so when we saw the face of the child, you could see the beaked nose of the child, and we knew that we were probably not actually dealing with the case of cornea plana, whereas there could be overlap with other congenital corneal diseases. You can see the excavation as in described in Peters anomaly in this AIOS20. Thank you so much.
Next, Professor Sushmita. Ma'am, your slides are loaded there. She'll be speaking on a use of a new device. Yeah, please. Dr. Meena, did you see such a thing? I've documented, over 15 years, one particular child initially had the dish-shaped corneal opacity. We thought it may need a keratoplasty, but as I observe over the years, the corneal opacification per se actually reduced. So we didn't have to do any intervention.
No, we never did any intervention, but I'm not able to say that they improved as such. The most funny thing is the 12q mutation, which is the long arm of chromosome 12, is associated with mental abnormalities. Children with that mutation are born developmentally slow, but somehow these patients don't carry that problem.
Slides, please. At the outset, thank you, Dr. Moodley. I'm a little overwhelmed in being in a pediatric cornea session because I'm all glaucoma centric, and the only thing I do is when the cornea doesn't clear, I wish Moodley was there, but I end up doing more optical iridectomies than getting their PKs done. So the photographs of all these children have been displayed with consent, but then I always think in a presentation with children, it somehow gives us context when we show the babies that we're seeing. So the UBM has obviously been an invaluable asset to us, especially when we have a white cornea and we don't know what's going on underneath, and it has helped delineate what we are seeing. So when we need to look behind a hazy cornea for a glaucoma perspective, it also helps us decide an appropriate clinical approach. So this was, for instance, referred as corneal opacity following trauma. And on history, it turned out that she'd actually had an LSV for ROP elsewhere, and then had some subsequent trauma, but she came with these Harb striae, and the presence of Harb striae in a baby doesn't necessarily mean it is congenital glaucoma. It just means that the pressure has been elevated prior to it coming to us. And what we noticed was actually pupillary block glaucoma, and we did do a combined trab with trab, but I think what had worked in this was actually just the iridectomy and allowing the aqueous to come, and the other eye was completely normal. So this was interesting because we had this clear area in the center, and we thought it was Peters anomaly, but then on the UBM it showed us this huge intracorneal cleft. And so we started recognizing these intracorneal clefts as a really bad prognosticator for clearing. So when we have stromal separation in the cornea right at the beginning, we know it's not going to clear. But after glaucoma surgery, it's wonderful how it's remodeled, and there's only a little bit of the excavation of Peters anomaly that's there. And it did clear in the periphery enough, and we've done the iridectomy, but I guess these children should be also subjected to an OPK. But this has been a prognosticator in a sense, and we call them intracorneal clefts, but they do remodel very well. There are unusual cases. So this baby again came with trauma and actually a little bit of hyphema. And the parents, and something that looked like a worm-like thing in the eye, but when we did the UBM, again it showed us that the pupil was all right, and this iris was actually pulled right over the pupil. And all we did, the gonioscopy on table showed up these characteristic Axenfeld-Rieger processes, and all we did was with a vitrector just chip this little bit of iris there, and actually this baby next morning was fine and didn't have glaucoma at all. So sometimes this aberrant posterior embryotoxon can pull on your iris and come right over, and if we didn't have the UBM, we would have had no idea as to what is going on, and actually there was a little bit of iridodialysis because of which there was a bleed. So this is something else very funny that we picked up in this white cornea. We thought it was acute hydrops, but with this big Descemet's tear, there was also a collection of fluid behind, and we wondered what this pocket was. So this is another thing that we found. It wasn't a cleft actually, but it was this small pocket of fluid, but that settled very well actually with surgery. So we have these funny things with glaucoma that we see, and the UBM has given us so many insights as to what is to be done. Well, when we see a newborn baby like this with a white cornea and a UBM like this, I think it is likely PCG, and I'm all right with this neonatal onset glaucoma, because something tells me that this is not going to clear very well because it's already white, but all this ground glass thing around is going to clear, and it's helped us prognosticate, and we can tell the parents that, look, she might have something central, but if you do the surgery in time, we might be able to salvage enough clear cornea to give some vision with an optical iridectomy. So in that sense, it's helped us once we have the UBM as part of our EUA. But when we see a diffuse haze, and again the UBM has helped us prognosticate, now if I see something like this and not exactly white, I'm pretty much sure that this baby is going to be good, because this is a huge cornea. This is almost 800 microns, but there is no white scar-like thing. And if they come early enough in the neonatal period without the stroma compacting, I sort of can say that this baby will do well, and they usually land up with, so if you do prompt CTT, they land up going to school and being normal children. But all white children are obviously not always PCG. This is something that we dread. If there's a posterior stromal defect along with a Descemet's defect, those are the ones where the central cornea is not going to heal. And it's not always just a Descemet's defect. It can be very, very large, and this intracorneal cleft is our bugbear. But we just go ahead and do as much as we can. And genetically, a lot of Peters anomaly that we see are CYP1B1. So they actually present with Peters on one side and PCG on the other. And I'm not even sure whether that semantic diagnosis is correct. We don't know that, but when we see a Descemet's defect, we still go along with the diagnosis of Peters. Sometimes the defect can be so big, so this looks like a cyst in the cornea, but since we had the UBM, we know that the entire lens is right there, and these eyes can be very, very tricky to treat, and mostly don't have too much of visual potential, but we have a chance to treat the other eye. So how does it matter? For instance, if you didn't have a UBM and you didn't pick up the zonular cataract, on table you probably might think that it's a little bit of white, but if we didn't have this, we wouldn't have picked it up. And this has really spurred our rubella story, because now we think rubella, this needs cardiac evaluation, this needs a hearing assessment. And earlier, I can confess that a lot of children who were developmentally delayed, quote unquote, simply had a hearing loss, and it's just that we didn't think of it because we weren't looking for them. It also helps diagnose complex anterior segment dysgenesis. This I learned this from Moodley, actually, not to go in at all, and we've recognized congenital primary aphakia, but the takeaway is that if you give them +14, +15 glasses, they are mobile, they are ambulatory, they can look into their phones, they have vision. So we used to give up on these with severe anterior segment dysgenesis, but the UBM has taught us to learn better. So when you have new toys, you want to play with them all the time. We know the AIOS2025 is a good non-contact device, but the swept source OCT has really been the game changer for us, because it takes 5 seconds to acquire an image. And when the retina guys can do their OCTs with the flying baby, we thought, well, why can't we do it on children? Now, this paper explains how to characterize the anterior segment OCT on the trabecular meshwork and the scleral spur. So we took this out of it and wondered if we could do it in children. And so we did our share of flying baby along with them and said, let's see what happens. So this is a garden variety PCG where I would do a GAT, 3 weeks old, nothing, the antenatal and postnatal history uneventful, everything else normal. And this diffuse haze with no stretching, but IOP is 12, CDR is 0.3, ultrasound normal. So all these come to us, and it's very, very difficult. We used to usually subject all of them to an EUA before we were sure that we maybe would not intervene and have another diagnosis. So we thought it's unlikely PCG, but what else? And is there any way to be sure? So this was possibly one of the earliest that we started imaging, and we were surprised that we actually could get very good images on the AIOS2025 in that 5 seconds with a swept source. And we could delineate the trabecular meshwork very well. We could delineate the insertion of the iris nicely on the ciliary body. And we had some way of saying that most likely our clinical suspicion is correct and it isn't really a glaucoma because I can't see any evidence of angle dysgenesis. So we didn't do an EUA, but decided to go in for genetic testing instead, and sure enough, it turned out to be a congenital hereditary endothelial dystrophy. So we thought, okay, let's carry this forward and let's see our children with glaucoma and what it looks like. So this was the usual kind of child which I would want to do with unilateral PCG. That is something which is troubling me a lot, this unilateral PCG, because I really don't know what's going on. But you can see this trabecular meshwork clearly here, and the iris is here, and this is the normal eye. And here, there is no trabecular meshwork at all. It's a very deep anterior chamber, but there is no TM shadow. So this TM shadow is something which really stuck. And we did a few more. So this was another late onset PCG. The one thing that you notice is this is why there is a posterior bowing of the iris in these children, because as the eye grows, the iris is inserted way up, and then as the eye grows, it just falls back. So that's the reason why we see a lot of posterior iris bowing clinically when we do a gonioscopy. But the hallmark was there is no TM here either. So this is Axenfeld-Rieger, both eyes, and this is a very, very severe iris hypertrophy. And again, there is no TM shadow. So it looks like aniridia. Genetically, we've recognized that this is usually a FOXC1 deletion, which was erroneously called aniridia, but these are actually the deletions of Axenfeld. Early days yet, aniridia is another thing which is troubling me because I don't know whether aniridia is just absence of iris or is aniridia a disease. Because we see a lot of absence of iris in severe iris hypoplasias, but they are not the PAC6 aniridia disease. So the 6-month-old child with aniridia, when we do an ASOCT, there's a stump in the iris, there is very little TM shadow visible, and we are very scared of doing anything to this baby, but then still there is some angle. This is a 6-year-old girl, and if you see, this iris stump is smaller and it's already getting on to wherever the trabecular meshwork should have been. Now this boy doesn't have glaucoma yet, this girl has glaucoma, but by the time this is a 13-year-old girl, and you can see the fundus shadows in this, when we did this, here you are, the iris stump has actually closed it. So it's helped in the sense that I would possibly do what David Walton called a prophylactic goniotomy in this, especially genetically, if this baby has the same variant as a parent does, because that's then PAC6 autosomal dominant aniridia. I would possibly do a goniotomy in this. I would do a combined trab with this because I don't think there is much of a collector channel there. But for this, I would possibly go in and just do a tube majorly, because I don't think a trab will work in this at all. And I'd be scared with this iris stump closing it. So that's how it helped. We had open angles, and we went ahead and did a prophylactic goniotomy. What also helped, as I said, was he had exactly the same variant as his father, who had glaucoma. And you can see this cleft here. So that's why I said early days yet, because I don't know whether this is going to close. I don't know whether this boy is going to develop glaucoma, but I do know that the father with the same variant has very, very severe glaucoma, and I want to save this baby if I can. Whereas this girl with aniridia and advanced glaucoma and nystagmus with low vision and 28 and 30 millimeters pressures and superiorly subluxated clear lenses. I don't want to go in superiorly at all, and she also has a ptosis, so the only thing she's looking from is inferior aphakic area. And that's how the lens is, and you can see the iris stump. So we planned against that and bilaterally just implanted a tube in the inferior sulcus, leaving the clear lens there, not touching it, and giving her aphakic correction. And we think this is possibly a better way to manage these children, but I hope we are right, because only time will tell. So it's helped in treating adult as well as childhood glaucoma, but it's given us more rational and informed choices of management. But still, technology we use as an ally, and as for all imaging, we can't use in isolation. Thank you.
Thank you, madam. That's excellent presentation.
And of course, I
yes.
invite all my cornea, pediatric cornea colleagues to the IPGS
Right.
and help us.
Yeah.
It's in Madurai in December.
Yeah, a lot of takeaways. So we'll move on to quickly next topic by Professor Radhika Tandon. She'll be, ma'am, you can take it to your presentations.
Good morning. Thank you, Murli, for involving me in this instruction course. So I was to cover preoperative evaluation, critical period assessment, and aiming at surgical intervention. So when you're talking about pediatric corneal opacities, one has to take a holistic view because patients don't come with isolated problems. And as we do know that there are several more hurdles in the management. Dr. Sushmita had also covered how there's so many EUAs which would be required, examination, follow-up, and so on. So essentially, when you're looking at the intervention, learning period, pre-operative assessment, etc., one is looking at the anatomical success, one is looking at vision, but as far as vision is concerned, it's the practical vision that we're looking at. We're not, some of them with the congenital opacities, we're not going to be aiming for 6/6 unaided vision. The aim in the initial stage is to give them adequate vision, to have at least their visual system develops, and then depending upon the situation, you will plan your intervention. Not to forget the importance of binocularity, stereopsis, and of course the comfort and follow-up. All of this needs to be taken into account when planning your intervention. And also it requires sometimes multi-system or interdisciplinary approach. There could be, whenever we are dealing with a corneal problem, there's associated problems related to the cataract, whether to operate or not, whether it's a dense cataract, whether it's a minimal cataract. Sometimes there may be just be an anterior polar cataract, and often some people would say, oh, this should be removed. But there's a small anterior polar cataract, the rest of the lens is clear, it may be better to leave it alone. In addition to that, whatever intervention you do, there is an associated refractive error. So careful refraction, prescription of glasses, and occlusion. These children are very prone to trauma and infections, as are all children. So there again, one needs to counsel and take that into account into whatever intervention you do. Strabismus and amblyopia, and then the corneal opacities. All of this needs to be taken into account when planning the intervention. The other important thing is that not all patients can come for follow-up, and also getting the information out there to get the people coming early. So here somehow we need to see, because often we still do get patients coming quite late, and they go from center to center, and they often do not present so early. So this is important. And then the tertiary care, of course, would be surgery, shared care, and follow-up. So, of course, we do know that success can be great, and several people where earlier they felt that pediatric keratoplasty has a very dismal prognosis. With the modern knowledge that we have, one can have good vision even with careful care. But one has to be aware that in this age group, the children are not going to complain. So it's the parents who need to be alerted, pre-op as well as post-op. And for example, you just guide them that if you find there's any change in the visual behavior, they're unable to focus, or there's some increase in the tears or discharge, some little whitishness appearing, constant rubbing, or the eye becoming a little smaller, or if you start seeing an abnormal whitishness, or if you have increased sensitivity to light, all these things are important to mention to the parents right in the beginning. So as I said before, multidisciplinary approach, and the cataract, the keratoplasty, secondary glaucoma. Largely it is, as anterior segment surgeons, we can manage the cataract, the glaucoma, and we have a reasonable knowledge of squint and amblyopia. It's the glaucoma which is a little difficult for us. So you do need a very good glaucoma expert who can help you with that. Sharing some insights regarding pediatric cases. The other important thing is the multiple interventions that you do. There is, even if the intraocular pressure is not high, the repeated interventions themselves can also lead to a progressive increase in axil length, and there can be a myopic shift. And the other thing is talking about the time to intervene. So ideally, we would like to intervene as early as possible, 3 to 6 weeks. However, sometimes the children are not fit for surgery. They may not be fit for anesthesia. They may be having systemic problems. So therefore, the window of up to even 6 to 12 weeks is acceptable when you're talking about corneal disease. There is better stereopsis and bilateral congenital cataract from the unilateral counterpart, as we know. And from that learning, one would be tempted to have very early intervention for keratoplasty as well. Now, keratoplasty in pediatric keratoconus has good outcomes but can encounter frequent suture-related concerns. Now, in pediatric keratoconus, now we have shifted from PK to anterior lamellar keratoplasty. That has made a lot of difference in the outcome. But not to forget that here again we do have the suture-related problems. So it's very important to make sure you have a protocol for having the patient come back and immediate attention if any such event occurs. The other important thing is that you have associated problems. So, for example, you can have patients with severe VKC, and you have to sometimes really balance their intervention. So, this little child would often come with extremely severe VKC, and to the extent that one was thinking that one's going to have to intervene, repeated inflammatory keratitis, and not to forget that in such situations, one may use a lot of steroids, and that is important to emphasize that you must come back for follow-up and never prescribe steroids in an open-ended manner. Always prescribe them with a defined frequency, duration, and do say review, and even mention stop, because there is a tendency that otherwise I think we can continue putting this for long. And here again we have an example of a clear graph, but if you can see that there's a divergent squint, so it's very important to emphasize the importance of patching and refraction. Similarly, you have patients coming with trauma, and this is a child who had PK at the age of 3 months, and so many years later, and initially unilateral PK was considered not at all worth doing, but that is not so the case today. Here's an example of VKC with a shield ulcer, and if the child is treated with AMG, you can avoid keratoplasty. So you need to have a holistic view. Another child with firecracker injury and has been treated promptly. So just a little bit about pediatric cornea, restoring vision. The other thing is that we also need to be aware about from the past the fact about the increased risk of rejection, failure rates, and poor visual outcome is what is generally used to be accepted. Now let's talk about the increased risk of rejection. So from the past, we should know what is the rate of rejection. We know it's high. There's no doubt about that. Now the timing of surgery, again, there is no general consensus depending upon which way you look at it, but as of today, as early as possible. Regarding the challenges during the surgery, Vanati will be covering that. Outcomes, when you look at the outcomes, even in high industrialized nations, they have found that the results cannot be universally successful. So if you feel an optical iridectomy would give you a better outcome, that is an option that you could consider. But what we would like to look at here is the overall mean graft survival was about 45 months, but the 1-year graft survival was less in eyes with glaucoma. So that's the important thing. So if they have associated glaucoma, the prognosis changes, and we need to have the glaucoma team on board straight away. And the ones who don't have glaucoma have a better survival. And the overall survival rate was 75% at a year. Now, looking at a study from our center, and half of the patients were able to achieve ambulatory vision. Looking at a publication from our center by Vanati and her team, in this case also there was very good follow-up, a reasonable number of cases, but graft rejection occurred in 12%. But look at what we have what we learned from here. The mean surgery rejection interval was about 10 plus minus 7 months. So as early as 3 months, you have to convey the message that from 2 months to 1 year, you have to keep them on very close follow-up, and the mean rejection treatment interval was extremely high, 10 plus minus 7. So that would mean almost 2 to 3 weeks. So that is again, so I'm just trying to explain that the abysmal results earlier were because that some of these things were not attended to, but by taking care of these issues, one is able to have a better outcome. And the third thing I would mention is also taken to consider the immunization. If they're going to go for immunization, we advise that they step up the topical steroids 1 to 2 weeks before, keep the higher level of steroids for 3 weeks, exactly as you would do as immediate post-op, because that has also made a huge difference. And a successful rejection reversal was 25% in this study because of the late presentation. So the ability to reverse a rejection is directly related to the time at which you intervene. So again, one cannot emphasize more that it's very important to get them to come early. And so this is the other thing that we need to do, monitor and keep looking at the results. Just giving you one example of a patient, because the question was what should be the workup, what should be the assessment of the intervention, and so on. So this was a 13-month-old baby. She was an adopted child, and they presented with history of whitish opacity, which was noticed since the age of 2 months, initially small in size and progressed rapidly. She was initially diagnosed as a perforated corneal ulcer and treated with topical medication elsewhere, and had been referred. And a preliminary diagnosis of keratomalacia was made in view of being fed with top feeding with diluted milk, and she was treated with vitamin A. She also had coexisting severe anemia and had received treatment for the same. So often we find these babies who are coming with keratomalacia also have anemia. They often have hemoglobin below 10. So the birth history was all right, no significant history, and near total elevated leukomatous corneal opacity with 360-degree superficial vascularization. The other eye had a leukomatous corneal opacity which was peripheral, and the remaining cornea was clear. So the initial impression based on this history was that it was bilateral post-keratomalacia, leukomatous corneal opacity with perhaps anterior staphyloma, and ultrasound was done, axial length, and examination under anesthesia was performed. These were the corneal diameters, and this is the UBM picture. The patient then underwent surgery with the Fleringa ring using Hesberg-Barron and using the lamellar dissection technique so that you do not enter the AC suddenly and hit the iris. There was a cataractus lens, and the capsulotomy was done, lens aspiration, 3-piece IOL was placed in the bag, donor button put, and this were the histopath findings, and this is the vimenting stain. So finally, the histological profile indicated that it was actually a corneal hypertrophic scar following a corneal insult, possibly by keratomalacia, and it is an atypical presentation. And from literature review, there have been 2 reported cases of corneal keloids, but the unique case highlights the importance of an in-depth history taking, surgical management, and the intervention in one eye, keratoplasty, the other eye, just observation with refraction and careful follow-up. Thank you.
Thank you, ma'am. It's a very insightful. You covered every aspect of pre and post-operative care. If the time permits, madam, what is the graft rejection reversal rate? In my practice, by the time they reach us, so they have a profound rejection, significant corneal edema, nearly 3/4 of them, they don't recover, meaning succumb to rejection. What about your experience?
That shows 25% reversal, so exactly 3/4.
Right.
So that was earlier, but now they're trying to, reduce those problems.
So I just want to give you perspective. In an adult, 3/4 of the cornea can be recovered, if we promptly treat them. So such is the severity of a rejection in a pediatric age group. Ma'am, are you ready?
Yeah. Just a minute.
Any questions to any of the speakers?
So
Okay.
when we address pre-existing glaucoma, everybody says it's a worse prognosis. Is it true after
True.
surgery for glaucoma? Because
Yes.
they seem to come back with even more glaucoma.
Right.
Our young person who is venturing into pediatric cornea now, I just keep saying,
True.
ma'am, if you refer me, आप साथ में पहले tube डालो उसके बाद." You put in a tube, then I put the graft in. But is that true?
True.
Do you
Even
combine it?
uncontrolled preoperative glaucoma is an independent risk
becomes a
factor.
problem, so they cannot
Post-surgery
receive.
also, I think, they do have something called a non-immune rejection following a trab or a tube. So both are not really good for a corneal endothelium. So quickly invite Professor Vanati. She'll be taking us through the pediatric keratoplasty steps and intraoperative challenges. Thank you.
Thank you, Murli, and I'm really so happy for attending this course in the morning, because all the earlier talks still add on to what we are learning in pediatric cornea. And I think our understanding is still evolving, and this is one of the most challenging scenarios we are managing as pediatric corneal surgeons here. have no financial interest in the mention of anything during the course of my talk. Considering this is catering to pediatric, I think developmental anomalies was the title of this instruction I see. So I'm just probably sharing 3 pediatric corneal opacity cases so that we can probably discuss the highlights pertaining to those cases here. So here you're looking at a congenital corneal opacity here, which is, as we would all have looked at, we would have called it Peters very easily here, but you look, the limbus is not looking normal, the iris is also not looking normal here, and we do have a particular, I think this also had an operated glaucoma in this particular patient here. So we'll go back to what we are probably looking at in terms of redefining the classification of congenital corneal opacities in these cases. So we have probably moved on, or there is an onus to redefine these cases as from what we thought of traditional Peters type 1, type 2, type 3 to now they talk about KID and KILD, KID or KILD, so which is keratoirido dysgenesis or keratoiridolenticular dysgenesis. I think both of these classifications, so the way we look at it, have their own pros and cons here. So when I was a resident training in Cornea, I still remember reading Kratchmer's where Peters 1 had an excellent prognosis or a better prognosis than Peters type 2 or type 3 here, where the pathology just involved the cornea and you probably had a lesser involvement of the iris or the angle or the lens in these cases here. Peters type 2 and type 3 are categorized, where type 2 you do have the iris abnormalities also involved, and the angular abnormalities probably are not that morbid here. But when you're looking at keratoiridolenticular abnormalities, you're looking at cases where you also have both the iris and the lens involved in these cases here. And this was helpful in prognosticating and how the glaucoma behaved in these particular cases here. So that really helped our understanding vis-a-vis looking at just as KID and KILD. But when you're looking at just KID cases, then these are cases where you pretty much, your prognosis is perhaps much better because your glaucoma is less severe in these cases. But when they move on into a keratoirido dysgenesis and iridolenticular dysgenesis, the glaucoma is more severe to treat, or if they didn't have glaucoma to begin with, they do invariably develop glaucoma during the course, or probably that was not picked up earlier on during the surgery. I still do not use a flaring eye ring in these patients here. I know Dr. Radhika always uses flaring eye in her rings, but I find it much easier not using. So that's one aspect in pediatric keratoplasty. It is always better to learn to train with using your flaring eye rings here. So here you've got a suction trufine. You've truffined it on here, so I still would like to do it without the posterior ledge, but I do land up getting a posterior ledge in there. So once you've opened up, you see the iris is anomalous here. The pupillary margins are also anomalous, but the angle recesses are pretty much okay in these cases. So these cases are otherwise behave like pretty much a conventional pediatric keratoplasty, which you would do probably for a CHED or for a PPCD or for any other acquired corneal blindness cases here. So this is a straightforward keratoplasty case, and what you probably worry is managing the glaucoma in these particular cases here. So in the interest of time, I think I will go on to the next video here. I'm sorry about this because my disk got corrupted when it was loading on the system there, and I had to reassemble this, and I didn't realize it got corrupted until I looked at it this morning. So this is particularly what I think I also concur with. I saw a similar presentation from Murli in one of the earlier presentations here. So I completely agree with what Dr. Sushmita was sharing with us, and I think it was like she was just wording my thoughts here. And when you see these intrastromal clefts here, and these invariably have the iridolenticular adhesions here, and as long as the lenticular adhesions are not there, it's corneo-irido adhesions, and they have these clefts. These cases do not do so well with their keratoplasty. They do have angle anomalies abnormal. The limbus does not look normal here, and you are also seeing that you have an anterior insertion of the conjunctiva over here, and this is pretty much a very small cornea, and I'm still wondering what I would choose in terms of the corneal diameter for my for performing or proceeding with the keratoplasty in these cases here. So I've also seen Murli do this, where you sort of recede the conjunctiva a little posterior here, and you try to fix it out there. And I did try this in I think 2 cases, but I think I will look forward to Murli's advice on how it really works, and it really did not help much. This otherwise you could see that the iris is looking anomalous here. The lens is not involved in this particular case, and there is a dilemma whether you would probably call these patients as partial sclerocornea, or you would just call them a variant of Peters here. But I think the new classification is here comes to help. They just say it is anterior segment developmental anomalies here. So you go ahead and finish the surgery for this patient. But the problem which I had with this, there was a persistent epithelial defect which was not healing, and it came up with all the other problems and resulted in a graft failure for this particular patient here. So that's one other scenario which I had in this condition, and that's another problem which we will have to worry about when we are managing these cases here. So this is the third video here before I finish here, and here you look at what again Shushmita was showing. You have this central clearing which appears well here, and an anterior segment OCT imaging helps in these particular cases when you could probably look at how this center one is behaving. I think I didn't have the imaging video incorporated onto this, it was separate. Again, proceeded on to do a keratoplasty for these corneas, are particularly small, deciding on the diameters for these cornea, and deciding whether they did have a pre-existing glaucoma which was missed because of the imaging difficulties, and because of picking up glaucoma in these patients is a concern here. As long as the lens is not touching, then it's pretty much okay, and you'll end up doing a conventional keratoplasty. But the challenge lies here in these cases is as much as the difficult procedure, it's also managing the postoperative problems, the persistent epithelial defects, because the limbus tends to be anomalous. Estimating the postoperative pressures in these cases, and what is the right procedure, what is the timing to deal with the glaucoma in these patients, what are the medications you need to give for glaucoma these patients. And if you cross these hurdles, the immunization, cross-reacting or crossing roads with the with graft rejection here, and that's complicating. And as was rightly pointed out earlier, these are eyes which do not have much vision here. So most of these parents who are coming from below poverty lines or low socioeconomic circles also do not pay particular attention that the graft is not doing well, and that's one of the reasons why they tend to report to us later here. So here we have multiple problems on our hands, but it is better to recognize that simple kids keratoiridodysgenesis without intrastromal clefts perhaps do better in terms of keratoplasty. And when you have an extensive kid very severe keratoiridal adhesions or keratoiridal lenticular adhesions, these corneas do not do well, and I am now started rethinking and counseling the patients when I am offering keratoplasty as a trial of giving whatever plausible vision these eyes can have. I think I'll stop here, and thank you for your patient hearing.
Thank you. There are nice invaluable intraoperative tips. Are there any questions to
So one question is, when you see, I'm still calling it Peters anomaly until you come out with the accepted international classification, or what to call them.
It is
So-
accepted. It is
so,
accepted and published as well.
Uh,
The Ken Nistel's group is the one who strongly
Kerato-
advocates this newer classification
I
of
know.
primary.
But I thought you all had
yes.
your meeting just now about the international
So,
classification. of-
unfortunately, I couldn't attend, and then that it was a pre-conference
no, what
meeting
I
on
was
W.
asking was, what is your experience of the posterior Descemet's defect in Peters anomaly? Because we very rarely see the iridocorneal adhesion or the lenticular one. Those are really rare.
Yeah.
Most of ours are the Descemet's defects or the Descemet's and stromal defects. But since they come to me, they're all with glaucoma. So I'm looking for a cornea perspective. Do you see
So yes,
more of
yes,
these?
there are variants of simple Peters type 1. This is what we usually conventionally called as Peters type 1, and I also prefer calling them Peters type 1 here, because they have the best prognosis in terms of keratoplasty and also in terms of glaucoma management in these cases here. But then this intrastromal clefts and this variability in the density of the opacity which you see in the central cornea does tend to happen. And when I see this variability, there is also a limbal anomaly in there, and and they sort of, cross with what we used to call as a sclerocornea. Whether it is a partial sclerocornea, some part of your peripheral cornea is also, your limbus is also involved. In those cases, your keratoplasty doesn't do well. If it's just a simple posterior stromal excavation defect, then they tend to do well.
Without glaucoma.
Without glaucoma. They tend to do well in terms of keratoplasty. I'm still talking about it with the perspective of how the graft does well. And I think the glaucoma takes a back seat for me. But then invariably it is always the glaucoma which sort of complicates the prognosis of our grafts.
We have a little over 80% 10-year graft survival for the type 1 Peters, whereas the type 2
Without glaucoma. That's my question.
My type 2s or the keratoiridogenesis, sometimes I feel so sad to see the graft growing, start the pacification or the failure starts as early as 3 to 4 weeks post-op. By the time I'm doing my second examination under anesthesia, the graft is already gone, the sutures are loose, otherwise they have persistent epithelial defects, and even if they cross the 3 months, they don't cross the 6 months.
What do you call the type 1 Peters? Without the
It's KID. No, if there's no iris, then we just say it congenital corneal opacity. But the classification which Ken Nischel's group gives is that the primary ones, that's the...
iridocorneal abnormality.
Yes.
Iridocorneal-lenticular abnormality. He wants to call that as a spectrum, not a Peters.
Dr. Vanity, are you able to see these slits on handheld slit lamp?
It's very difficult to examine these children. We still haven't used a handheld slit lamp on kids because for the reason we are yet to acquire one here. We have an IOCT and we have a UBM which looks at these, so that's what we used to look at.
Thank you, Dr. Vanity. It gives me distinct pleasure to invite our next speaker, Professor Deepak Edward. He's a world authority when it comes to the glaucoma as well as a pathology. Sir will be giving a lot of insights about each of these conditions. Thank you, sir.
Thank you, Dr. Murli, for inviting me to give this talk. So I'm going to speak a little bit about the pediatric cornea from the pathology perspective in health and disease, and give you examples of some of these diseases. So we'll briefly touch on embryology and some of the conditions we've already spoken about and look at the conditions from a pathologist perspective. So I think this is kind of a revision of what we've known, but where the cornea arises from, remembering that the epithelium comes from the surface ectoderm, rest of the cornea mostly from the neural crest. And then in the fetal cornea, you have multiple layers of epithelium as well as multiple layers of endothelium. There's, physical dimensions of the cornea are well known in preterm, term, and young infants. But the sad part is we really don't know anything, very, very little about the responses, the composition, the molecular pathology of the pediatric cornea. It's a huge gap in the literatures, and I think that's one of the reasons we don't understand a lot of things of why these corneas behave differently. And this is a stimulus to people to try and look at it. We have the tools available today to look at these very easily. And I think it's worth looking at, and I think it'll help in managing many of these conditions that we see as the pediatric cornea specialists see. So many causes of pediatric corneal opacification, and we've talked about this a lot. So I'll show you some pathology. So there are two cases here. The first one is the one up there. This was a painful blind eye, actually from the University of Illinois archives from the 1930s. You can see your stromal cleft that you see there. There's no decimase. That's actually the lens capsule sitting behind the thin cornea here, right? And that's the lens there. So this eye was a very interesting eye. This actually I saw about 10 years ago as an autopsy eye. Someone called me from the autopsy lab saying that there's a corneal opacity. And it was a rare chromosomal abnormality with Peters anomaly. So it shows a lot of interesting features. Of course, the lens is stuck behind the cornea, as you can see. Decimase ends kind of somewhere like here, and then there is this peculiar accumulation of cells right here in the center, where there seems to be an arrest of the cells not being able to migrate centrally. So I think one of the ways, as Morley and others have looked at this condition, is to kind of perturb these cells and see if you can, they can lose their contact inhibition and grow across that defect and cover that, and that may be the basis of these cells. What makes it stop here, we don't know. The second feature I want to point out, as Dr. Sushmita had said, is to look at the angle here, okay? So here is the iris, like most congenital glaucomas, the whole ciliary body complex is often moved forward, right? And then you see no trabecular meshwork, and you see no Schlemm's canal in this baby. So this is probably one of the reasons why, classical procedures don't work that well in some of these patients, and this is a high magnification of this particular view. Sclerocornea is another interesting condition. I think we've touched on it. I'll touch briefly on the pathology, and it's kind of fascinating. I mean, it looks like sclera, the cornea. And if you look at, this is a normal cornea and some sclerocorneas. Bowman's is absent. The corneal stromal collagen kind of is irregular, thickened, looks like sclera, right? It looks very much like sclera. And the cells are a little paucicellular compared to the normal cornea. But then if you look at the immunophenotype of the cornea, so the main glycosaminoglycan produced by the normal cornea is keratin sulfate type 1, right? And this expresses normally. So you have, it is really cornea, but the assembly of the fibers of the cornea are like sclera. So the scleral immunophenotype is not there because sclera contains different molecules, and but it's really cornea which behaves like sclera because of this, we know it because of the keratin sulfate content. So we've seen several cases like this and published several case reports on different types of sclerocorneas, and the immunophenotype is very similar. CHED, as you all know, is again a condition where you have loss of endothelial cells from these genetic mutations. And one of the hallmarks of CHED, of course, apart from loss or attenuation of corneal endothelial cells, is marked thickening of decimase membrane. And you can see a age-matched cornea, a normal cornea compared to one with CHED, where you have a very thin decimase membrane, abundant endothelium, here a very thickened decimase, and a very attenuated corneal endothelium in CHED. So I think Murli is going to talk a little bit more about corneal keloids. I just wanted to make a few points here. I've looked at several specimens of corneal keloids in Chicago and also with Murli, and it has an interesting, some interesting clinical points that can be made. So these are lamellar keratoplasty specimens, and you can see there's this very sharp demarcation between normal and abnormal stroma. So the stroma can be very loose, such as this, with very plump-looking fibroblast-like cells. So one of the questions is, what is this tissue, right? Is it cornea, or is it, sort of abnormal collagen type 3? How does it behave? What is it? Then you see another phenotype of the cornea where the stroma of the keloid is much thicker or mature. The scar looks mature, as you would see in the pathology, and this would be more of a whiter scar. So lots of different types of changes where you see this loose connective tissue, more vascularized tissue, but always a sharp demarcation zone between normal and hyperplastic scar. So this is the take-home point here. So number one, this is the junction between the keloid and the normal cornea. And again, keratin sulfate. So the hyperplastic scar is not fibroblasts from elsewhere. It really is the corneal keratocytes that are activated that form the hyperplastic scar. The fact that they are producing keratin sulfate just like the normal cornea. So that's point number one. Point number 2 is, and you can see this across the spectrum of hyperplastic scars. The second interesting thing is if you look at, myofibroblasts express the protein smooth muscle actin. And here you can see the brown stuff is smooth muscle actin. This is the normal cornea. And this is when the scar is loose. They express these molecules inside the scar. But interestingly, if you look at the more so-called mature scars, and you can see that even though the cells look really plump, they don't express the myofibroblasts. So after a while, they quieten down, the cells. But at the junction between the keloid and the normal stroma, you see expression of these myofibroblasts. So the question comes is, okay, well, these are the ones that are probably going to produce a keloid. Should you be taking out a larger piece of lamellar tissue when you take out, the cornea, or you excise the scar, do a lamellar keratoplasty, and take out these myofibroblasts out of the equation? So MPS is another interesting disease. This is, I think, a typical picture, courtesy Dr. Murli. And if you look at the cornea itself, it's also very interesting. Number one, it is very, very thick, as you can see. And if you stain the corneal cells with Alcian blue, you can see expression, accumulation of mucopolysaccharide in the cornea. So unlike macular corneal dystrophy, which kind of does the same thing where you have deposits of mucopolysaccharide, these corneas are like 1,000 microns, 800 microns, and for glaucoma people, they can be hard to manage. You don't know what's going on. Discs are normal, pressure is high because of a thick cornea. On the other hand, you have a patient with macular corneal dystrophy where the cornea is thin in those patients, right? So, it's another interesting disease. So coming to congenital glaucoma, I think we've kind of spoken about this already. But I think Dr. Sushmita nicely pointed out the issue about the utility of imaging and looking at diagnostic. But the point I wanted to bring out here about the Hauptstria is that when we see specimens in the lab, we're looking at end-stage disease. But the point is that these corneas do lose endothelial cells. When these breaks happen, and they do decompensate over time. So I think that's the point to realize here. So we touched upon this again, but I think it's worth emphasizing that a lot of these angles don't. And I have some eyes from other conditions which I didn't bring, like aniridia or just very, very severe PCG, and the angle just doesn't form. And that kind of explains why probably tube-like procedures are a better choice in those patients. I wish we had better ways of imaging pre-op to be able to tell which ones to approach in which manner. So in conclusion, we have unique features of the developing and pediatric cornea, and I would urge young people maybe to work a little bit more on many aspects of the pediatric cornea. And the pathological features vary among causes, and I think once you understand the features, I think it'll be a key in developing new therapies for these group of conditions. Thank you very much.
Thank you, sir, for a lucid presentation, and you showed us what's happening at the cellular level. Are there any questions to Dr. Deepak?
Can I ask a question?
Yeah, go ahead, please.
Is there a difference in the primary pathology of the keloid in patients who don't have recurrence versus those who have recurrence? Is there a way in which pathology will guide us saying that look for recurrences in these kind of patients?
The short answer, I don't know. Yeah.
Just not related to this, but a cornea question in the sense, why are aphakic children, what happens to the cornea? Why does it become so thick and rigid, even if it's clear? That's a question with the IOP measurement, which is always troubling.
So, like I said, we don't understand the behavior of the pediatric cornea, in many, many ways. And so, why some of these corneas are thicker and why they behave that way. Don't know? No, no.
But
So-
is the lens somehow protected? Because
I've
I've asked Sonam to do pachymetry before she does the
Right.
cataracts. And 3 months down the line, those corneas are not only thick, but they're also very rigid.
Rigid.
So when they sent to us with the 28 mm mercury and the disc, so the disc is the only thing that we have to follow.
Yeah.
So what happens when?
Yeah, so the behavior, the response, I think is different, and I think those who do pediatric cornea know that. I mean, one thing I can tell you, we've done a study looking at the cross-linking of the cornea in children. The cornea is not cross-linked at all, the collagen in children. And that's one of the reasons why when you try to hydrate a paracentesis, the wounds don't close. That's why you have to put a suture. And that's because of very, very poor cross-linking of, and so as we age, we cross-link. And we see that in the sclera, how it behaves, right? When you try to do a trap flap, and junior resident is horrified when they see the sclera kind of curl on itself and become shorter. And that's the lack of cross-linking. So that we know for sure.
Is there a term, intrauterine infection affecting cornea? Is that at all an entity causing unilateral cause of? Because I many times that seems to be the diagnosis of exclusion in many of the.
Theoretically, it's possible, right? I mean, you can have organisms cross the barrier and do that, but why specifically the cornea? I mean, often.
Has it ever been proven? Because I have not read so much of the pathology, so okay.
Not that I know.
So that's good enough for me that if you say so.
Yeah, sorry, sir, I'm not speaking in a keloid, so I'll try bring a different dimension. So just wanted to see the impact of, what these families have to go through if they have a child with a congenital corneal abnormality. Again, I thank profusely Dr. Deepak Edward for a brainchild behind this particular project. And I learned so much from, this project. So globally, it is estimated that vision impairment costs about 168 billion annually productivity. So the corneal blindness seems to be one of the greatest economic burden. The reason is, the corneal abnormality not only have an early onset, but also one lose significantly more productive years due to the disability associated years. So therefore, the timely and a cost-effective intervention is a key in minimizing or mitigating the blindness related to the. We have several publications from our community ophthalmology. They have screened, extensively a lot of RAP studies, and what we found about nearly 11% of all children in a blindness have had a corneal abnormality. In the Western Maharashtra, they have showed about 22% of all children in the blind school had a preventable corneal abnormality. It could be acquired, it could be congenital, and once a child has such a defect, so it is beyond the physical disability. It may cause a psychological, emotional, socio-economic challenges. I have seen in my own practice there are several families which were broken thereafter, they have an incurable, blindness in a child. Okay. Because the parents may not accept, they tend to go through a different turmoil and tend to have a denial, blame, so on and so forth. And we were trying to, see, how these families cope up. And based on some of the studies, not only these are the various prevalence of, etiological agent causes of childhood blindness. It not only directly impact the child's education, and eventually they have a limited, employment opportunities and overall reduced quality of life. So we just wanted to see, how it dallies in terms of, it impacts not only child and the family. And as we know, and both elegantly presented by Dr. Radhika Tandon and Vanati, diagnosis directly impact anatomical outcome. There are certain conditions which have extremely poor outcome, certain have extremely good outcome, like a type 1 Peters anomaly, CHED. We have well over 90% 10-year graft survival, as against sclerocornea, keratomalacia, and a type 2 Peters anomaly have a abysmal poor. Oddly, handful of cases can maintain a corneal, clarity after 1 year. So determining the visual potential, that is a risk of amblyopia, which determines functional success. We don't want just to have a clear graft. Child should see through it. It does impact, the functional quality of a child. And presence of ocular comorbidity, as Shushmita was rightly pointing out, particularly glaucoma, aphakia, they can actually affect the longevity of the graft. And one of the most important thing is the judging ability of the family to participate rigorous post-operative follow-up through and a visual rehabilitative journey is a key for a overall keratoplasty. So the very premise of our work is based on this last, the socio-economic. I think, more than anything, I think this is one of the key indicator for a longevity of the graft. In the interest of the time, I will just only go to the results. It was an online survey calculated, did with one of the freely available, application. So what we did is, we interviewed about 255 families and slightly male preponderance and nearly 86% over the telephonic conversation, and 35% of them were acquired, remaining are all congenital abnormality. And most of them they reached after the referral, meaning 90% of them had a prior intervention or a treatment diagnosis elsewhere. And when they presented, average age is around 4 years, and at the time of interview 10 years. And if you look at geographic distribution, mostly from southern India, then the western part, and also some of them are a northeastern part. Wherever parental consanguinity is much higher, where congenital abnormality are much more, and elsewhere particularly Bimari states wherein you have an acquired right from keratomalacia, trauma, injury, and so on and so forth. So about 40% of them are joint families and single mother. These are the subset where we had extremely difficult for a follow-up, and they have a poor accessibility right from the water, transport, and primary health care. And many of them were traveling, more than 500 kilometers only, because of financial constraint. Nearly, 26% of them did not come for a follow-up. That means, eventually these grafts will succumb. Whatever, maybe the etiology, the effort we have put in, approximately 40% of the families, and they are much beyond 500 kilometers. That means, travel expenditures, loss of income, wages, and so on and so forth. And we did use a Kuppaswamy modified social economic scale for the current year. And this again elegantly shows with higher disposable income, they tend to opt for a paying category, whereas nearly 2/3 of them lower to lower middle socioeconomic status, where LVPI has a provision to provide absolute free treatment. And of course, they have to take care, medications, travel, many other issues. Nearly, as I said, 2/3 of the families are lower socioeconomic. It's not only affect the child in terms of, education, clothing, vacation, and also the family. Family have to forego all the recreation, better food, social gathering, and a proper nutrition. It does impact the other sibling as well. And nearly, it is one of the noteworthy findings, 60% of these mothers have to quit the job to become a full-time, child caretaker in all these cases which had a keratoplasty. And a child, if they have an impaired vision, none of these children have a 20/20 vision, they have a good ambulatory vision, yet, for a schooling, for other things, they did have a difficulty where one of the parents have to really help them. So what our study actually shows that, majority of them low-income family, they may have a lower education and a lower, disposable income, and makes, it is a very difficult. Nearly 40% of them, end up spending 54% of their annual income on a child's care. This actually deprives not only the family's resources and also on other child it, impacts. And majority of the cases where we don't have any government support. And again, losing working mothers who have to sacrifice their career can also directly impact the family. So the key message is that we don't have preventive measures. We don't have a robust fetal registry in India to document every defect, and don't have a proper access to the genetic counseling. And overall key is just to alert the advocacies, see that we have some stringent robust measures in place. I think prevention is the much more important, and that was the key message wanted to give from this particular study. And also we need to strengthen the system to support financial aid to such families to cope up. It is really difficult for the lifetime for the family and also child. I thank all my collaborators in putting together this project. Thank you for your kind attention. So we'll take any questions. I'll request, Srinivas Avadhanam. He'll be delivering a keynote address on a collagen cross-linking. Over to you, sir. If there are any questions, we'll take at the end. Thank you.
Thank you. I feel fish out of the water. It's so much brilliant presentations, pediatric ophthalmology, so too complicated for me. Right, this talk is may not be directly related to pediatric and congenital, but some aspects spill over into that. Right. First, you all know, as Professor Edwards said, cross-linking doesn't happen in children, and it gradually evolves as we age and mature. So the cornea cross-linking is medically done to enhance the strength in conditions such as keratoconus and many situations where the cornea is a bit weaker. Right? In this procedure, as you all know, that epithelium is ripped off, and then we soak the eye with riboflavin for a certain time, and then expose the eye to ultraviolet light, and that increases stiffness of the cornea by increasing the covalent bonds. So the talk is to do cross-linking for conditions other than keratoconus, where it is applicable. So we go by each condition, but not into excessive details. First is a post-refractive surgery corneal ectasia. This is quite common. These corneas behave like keratoconus. I just look at the synapse of the studies. So there are so many studies that have been upcoming and being published, but I just focus on some of them. So 26 eyes in one study, there's 2-year follow-up, that shows 85% stability. And one other long-term study also shows that it is more stable. So that shows that cross-linking works. And importantly, the vision has improved and Kmax also a bit reduced. So that refractive ectasia is something that can be treated very well with cross-linking. Another condition is pellucid marginal degeneration. These patients present in the middle age, and they do not have the classic features of a keratoconus. However, you can see a small area of thinning. So in this condition also, although it is rare, cross-linking does work, but requires a slight decentration and a modified protocol. And others are Terrien's marginal degeneration. There are very few cases that have been published. It also works, is encouraging to see that the cross-linking has an application, but you still have to modify the protocol and slightly decenter the exposure. Other condition is infectious keratitis. When the cross-linking is done for this procedure, it is used with a different name called PAXCXL. That means that's called photochromo activated cross-linking. It's interesting to see that ultraviolet light is actually a sterilizing agent. It can act against many of the microbes, so that helps in a way to treat the corneal infections. It's usually used as an adjunct rather than a complete replacement of the treatment. It may have some applications in pediatric ophthalmology if you have any children that they are not compliant with the eye drops. As you go through bacterial keratitis, some studies that are not randomized controlled trials, but they have comparative studies. They compared with the antibiotics alone with the cross-linking plus antibiotics. The cross-linking treatment has achieved faster reepithelialization and better visual acuities, and also it is, in some studies they're brave enough to do that, just cross-linking and without antibiotics. They showed that it is as effective as cross-linking as antibiotics. So this is a very, very promising tool. And fungal keratitis, sadly fungal keratitis, fungi are generally, in vitro studies have shown that fungi are not that much affected by the ultraviolet light. But however, there is some mixed reports. It works in some studies and it doesn't work in some studies. I guess whenever it works, it may be that the fungal keratitis is not too bad, or there is some mixed infection with bacteria. And viral keratitis, I don't know, some people have tried it, but it is interesting to see that one of the complications of cross-linking is recurrence of viral keratitis. So it may not be a good indication. And acanthamoeba keratitis, acanthamoeba are also not affected by the ultraviolet light in vitro, but some studies have shown that it works. It probably because of the mixed infections or some other things. So it is not fully settled. Bullous keratopathy, I think it may have some application in your pediatric corneas as well. I first thought why it is a temporary condition. The pure problem, main treatment is surgically replacing the cornea. However, there could be a supply problem with the donor tissues, and patient could be waiting, and sometimes they are not suitable for full keratoplasty. In those cases, cross-linking can help to achieve some reduction, and that's what you needed. And post-keratoplastic cross-linking, I think this is also pre-keratoplastic cross-linking. I think cross-linking of the donor corneas has been tried. It reduces the subsequent rejections, reduces the astigmatism, and also it increases the strength of the cornea. So that may be one other evolving area. We need to wait and watch the space. And scleral cross-linking for progressive myopia, it may have some applications in pediatric ophthalmology as well, because the myopia is known to increase globally, and by 2050 they say 50% of the population will be myopic. So there are different ways people do this scleral cross-linking, so I'm not going into much details, but that is something we need to understand. And overall summary, how cross-linking is effective, is definitely highly effective in ectasia as post-refractive surgery. And bacterial keratitis, it works quite well in many studies have reported, but rest of the things are either experimental or variable. So that's something that we have to watch the space. So in conclusion, cross-linking is an evolving technique. It's quite recently in the market, and people are expanding the indications to many areas. So I think it is a promising tool. And I would say that this is one of the disruptive innovations in ophthalmology that happens every 10 years. It changed the way we treat many conditions, right? So one thing that please look out for this, our upcoming textbook, very comprehensive textbook on keratoprosthesis, which is our first ever thing. And thank you for your time. That is not subtle actually. In vitro studies have shown that acanthamoeba is resistant to many of these things. Whenever there is a problem, acanthamoeba quickly forms a cyst, and it is resistant to many things, even to the 100-degree temperature and infrared light, many things. So acanthamoeba is a tricky thing. Probably the protocols needs to be adjusted. That's something that is not done. And because it's still evolving, we don't know. And so many agents are for cross-linking, apart from riboflavin, many agents are being tried. So we have to watch out the space. But for acanthamoeba, I think it penetrates deep into the cornea. The diagnosis is the biggest issue. If it is in the early stromal stage, the prognosis is good. Even advanced stages is not good.
Have a quick photograph, please. I request all speakers.